This video highlights the steps for safe surgery when the posterior capsule is already open in the context of cataract surgery. This is an 11-year-old child with posterior lenticomus. Paracenteses are fashioned, followed by a 2.4mm keratome incision. This is a white cataract, so in order to visualize the anterior capsule, vision blue is inserted, as you see here. It is then irrigated before a soft shell technique using dispersive and then cohesive viscoelastic in order to protect the young corneal endothelium. The capsulorectus is initiated with a cystotome, and then capsulorectus forceps are used with tearing forces directed centrally in order to prevent the elastic capsule of the child tearing out. We prefer to make the capsulorectus smaller than intended and then to use a double pass technique where we can enlarge the capsulorectus using an overlap, as you see here, in order to finalize the capsulorectus at the intended size and shape. We don't carry out hydrodissection when we fear that the posterior capsule may be opened, but instead carry out gentle viscodissection, again using a dispersive viscoelastic here under the anterior capsule. Phacoemulsification is carried out using OSHA's slow motion settings with reduced aspiration, vacuum and bottle height, and once we see the posterior capsule open, we put some dispersive viscoelastic into the gap. Each time we remove the instrument, a fluid viscoelastic exchange is carried out, and we're putting some dispersive here to carry out some further viscodissection to try and free up some of the soft lens matter and epinuclear shell. We prefer using a manual technique here to supplement the automated bimanual vitrectomy on IA cut in order to aspirate the soft lens matter and then bring it into the central portion of the eye and then use the vitrectomy to remove the soft lens matter. This is safer, even though we don't appear to have any vitreous here. It prevents the risk of traction on the vitreous should it become manifest. And then swapping hands here, again a closed system with bimanual vitrectomy and irrigation. Now putting some cohesive viscoelastic into the capsular bag and also creating some space in the ciliary sulcus, as you see here, to accommodate the haptics 3-piece intraocular lens. Lens can be injected, but when there's a large ellipsoid posterior capsular defect, as you see here, we prefer to fold the lens and then dial the haptics into the sulcus and capture the optics of the capsular bag. You can see at the end the lens is well centered. We now put some trimethylene in order to ensure that there's no vitreous in the anterior chamber, and then again use this bimanual vitrectomy in order to just ensure there's no vitreous here, which there is not. And we use a tenovical suture in a butterfly configuration with a knot buried into the incision. Some stromal hydration here, and then we aspirate the remaining viscoelastic before placing some myocol and cefuroxime into the anterior chamber. This concludes a case of a pre-existing posterior capsular defect, and cataract surgery is completed safely with a 3-piece intraocular lens and optic captured into the capsular bag. Thank you very much for your attention.